I'll take care of it.
Hello.
Hi. So for you, it's the nighttime. For me, it's the morning. Such a
Yeah,
quick.
exactly. The end of my day and the beginning of your day. Crazy how across the world we can connect and be on somewhat of a similar page.
Okay, so I'm Lori Novick, coming to you from Efrat, Israel. I'm a Yoetzet Halacha and a Yoetzet Halacha fertility counselor.
And I'm Sahar Wertheimer. I'm a reproductive endocrinologist in Los Angeles.
Okay. So today our topic is from the basics to BRCA, and talking about PGT, which is pre-implantation genetic testing. Sarah, would you like to give us an initial, like, first working definition of that? We'll, of course, get into the details a little bit later.
Yeah, so pre-implantation genetic testing refers to testing embryos before they are implanted. So when a couple is doing IVF and going through, creating embryos from a sperm and an egg, even before it is transferred to the uterus, so before conception, we can test the embryo. We can test it, do a cellular biopsy of the cells that will later become the placenta and test the genetics of those cells to check for different types of genetic mutations, and we'll talk about specifically which kinds in a bit.
All right, fantastic. That's enough for us to start, I think. And today we have a few topics that we're going to be talking about. We're going to start by talking about some of the considerations when we talk about major interventions in as I get in fertility and genetics. Then we're going to move to talk about two different types of PGT, PGT-A, PGT-M. Then we're going to talk about specific, very interesting cutting edge issues. First, late onset disease, which also includes BRCA. And second, the question of sex selection, choosing the gender of a child through this process. Let's start with our first topic, talking about interventions. And Sarah, why don't we start with the medical and ethical aspects of this issue?
So ethically speaking, okay, so medical issues with PGT, in the IVF world, we think about uh, pros and cons. Pros, we know that if we have a tested embryo, and I think that this will become a little bit clearer once I discuss a little bit further what PGT is. But we we know that if we have a tested embryo that is matching good genetics, that there's a higher implantation rate, a higher success rate with transfer. Cons can be ethically, what are we selecting for a better gene pool? Are we selecting, are certain genes potentially linked that we're unaware of? And maybe we are kind of engineering a different kind of pool. People will ask a lot of times, what about designer babies? Are you creating designer babies? A lot of times I have to clarify for patients that at this time we are not, testing for blonde hair, blue eyed babies. That's not what PGT does. But I guess in a sense, will that one day be possible? Maybe. And so that's kind of part of the ethical discussion of PGT testing. To what degree what are we going to test? Where is it ethical to test into? And where does it start to become a little bit extra?
It's a really interesting religious issue as well. Like, there's a midrash in Breshit Rabbah that talks about 7 things that are mechusim mibnei adam, that are hidden from human beings, sort of like beyond our scope. And one of the things they list is ma be'ibura shel isha, what a woman's got in her pregnancy. And there's a Gemara that talks about a conversation between Yeshayahu and Chizkiah, where basically Yeshayahu says to Chizkiah, who's reluctant to have children because he understands that his children are not supposed to wind up being tzaddikim, which says, "Badi kavshi d'rachman alam alach." Like, why would you get involved with these things that are sort of in God's province? So there's definitely a strain in Jewish thought that thinks about some of these issues as being really beyond what the human being should deal with. And on the other hand, we have a strain in Jewish thought which says, "Rapo yirapeh." that we have the
Mhm.
permission to heal, that God gave us the ability and permission to perform the things that we can.
Mhm.
And not only that, but there's a broader question, which is really, why should we say that we can't do this sort of thing if we have the capability, unless there's a clear halachic reason why it
Mhm.
would be prohibited? There's a Tiferet Yisrael on the Mishnah who says, "Shekol davar shelo nideh tam la'asro, mutar hu bli tam." The things that we don't have a clear reason to prohibit should be permitted without there being a special or specific rationale for them. So it's not totally clear why this would be an issue. We could say maybe this is one of those things that was not explicitly prohibited, and therefore it should be permitted. So what we're going to do next is we're going to hear Sarah's going to go into more detail about what these procedures really are, so that we can have a really solid medical understanding of what they are before we start breaking them down more.
Okay, so basically, pre-implantation genetic testing, like I said earlier, just to recap, we can test the embryo before conception, test some cells, as you can see here, the cells that are on the perimeter of this embryo. I don't know, can you see my arrow or no? Probably not.
I don't
But
see
anyways,
your cursor.
the cells that are going to become the placenta, we take a little biopsy of those cells and we can test them for genetics. There's two main types of what we can test for. The main one that we kind of extend in America, at least, to almost all our patients is called PGTA. And so if you show the next slide,
You
oh,
got
can
it.
I can control? Oh, I can control too. Check that out. Yes. So sorry. Yes. So PG. So this is the part that becomes the placenta. This is the inner cell mass that will become the fetus. This is the pipelle that takes a few cells for biopsy. And what I like here is that this little depiction of the petri dish with the green checks and the red X's shows that we're not really changing the nature of the embryo. We're just revealing what it really is, and that I think is a really important part for people to understand, especially when they say to me, can you help me have a boy or a girl, like sex selection? It's not that I'm making the embryo's nature any different. It's just that I'm revealing what it is. So when you talk about division of a cell, right, you get chromosomes from mom and chromosomes from dad, and they combine, and then they need to redivide into making embryos of the offspring. So if the chromosomes can divide the way they're supposed to evenly, then you have this normal division picture where you can see every embryo ends up with the right amount of chromosomes, one copy from mom, one copy from dad. However, a woman's eggs are around since the beginning of her life. She's born with the most amount of eggs she will ever have. It decreases from there throughout her reproductive lifespan. Those eggs that were in her ovaries since she was born, whenever she's ready to use them, come out from the vault and they combine with the sperm and they create the embryo. So, as you can imagine, if they've been sitting around since the beginning of her life, that the cell machinery that combines with the sperm and then redivides becomes a little bit sticky. And so the might not be such a clean break in chromosomal number. And so what can happen is that she can end up contributing the egg, that the faulty egg, let's say, can end up contributing an extra amount of chromosomes or a decreased amount of chromosomes. And so the offspring, as in the two other pictures, does not give the right amount of chromosomes off, one from mom, one from dad, but rather will give an extra set or a decreased set. And those offspring, usually we say there's an all or nothing phenomenon in the first trimester. They won't even implant if they're abnormal chromosomal number. If they do implant, most likely it'll end up in a miscarriage, which is why miscarriages, as we know, are much more common than people think. Or thirdly, it could progress to an abnormal pregnancy, which we pick up later on prenatal screening, for example, or prenatal invasive testing. And then a woman is forced with a decision of, how do I continue this pregnancy? Do I not? She'll ask a Rav, all the controversy surrounding Roe v. Wade these days, et cetera, et cetera. So Majority of the time, they don't implant. And that's what leads to unsuccessful transfers. If it was an untested embryo, most of the time we think it's abnormal genetics of the embryo. And so PGT, just to, go back to my first point of it brings you to a more successful pregnancy earlier because we know this is a normal embryo and we're implanting a normally genetic embryo. And most of the time that does lead to a normal pregnancy.
Okay, so in terms of PGTA, we're talking about chromosomal abnormalities.
Exactly. And because chromosomal abnormalities includes the X and Y chromosome, we can tell gender. So sex
Mhm.
selection is PGTA. We can tell if it's 46XX or 46XY.
Okay, great. And then we'll talk a little bit more about that in more detail
Yes.
moving forward. Okay. And then something that we had started to talk about when it came to PGTA was the question of mosaicism and also some recent controversies about it. Do you think you could speak to that as well?
Yeah, so when you were asking me about some of the medical and ethical decisions or pros and cons of PGT. So one of the arguments against doing PGTA, as a woman gets older, her eggs become more chromosomally abnormal. So in younger women, we think the percentage of her eggs that are abnormal is less. So if you're, 35 years old, just to give you a ballpark, maybe 50% of your eggs are normal and 50% are not normal. If you're younger than 35, majority of your eggs should be normal. And so some people will argue that in the younger patients or in the older patients that have had multiple failed transfers or embryos that are not developing in vitro, are not making it to the embryo stage, perhaps for these patients we shouldn't be testing. Why? Because there's something called mosaicism where different cell lines exist within the same embryo. And so some of the cell lines may be those abnormally divided ones with the abnormal instructions, and some might be normal. And so when they get a biopsy of the embryo, I'm sorry, remind me, can you see my cursor?
No.
Oh, okay. So when you take a biopsy of the embryo, like this little picture underneath the example one, they take a biopsy of the cells that are going to become the placenta. As you can see in that biopsy, some are orange and some are blue, meaning some are abnormal and some are normal. And so mosaicism basically means it's comprised of a different, like it's not totally abnormal and it's not totally normal. It's a makeup of the two cell lines. And so there can be different testing modalities have different thresholds for picking up on mosaicism. And so, if something meets a threshold of mosaicism, most labs will not implant that embryo because the chances that it could be abnormal are greater. But we do know through some data and some experience that these mosaic embryos, once they interact with the uterus, actually have an ability to autocorrect, which is very cool. You can potentially these mosaic embryos could end up being a totally normal fetus. That's one. And two is that potentially, even though we got a biopsy of these abnormal cells, the actual inner cell mass might be normal. What's going to become the fetus might actually be normal. Because remember, with PGT, we're biopsying the cells that will become the placenta, not the cells that will become the fetus. And
I,
so maybe we're excluding normal embryos. So their argument is if it's all or nothing phenomenon of implantation in the first trimester, let's let women take that chance. Let's not remove these potentially normal embryos from them and give them that added percentage. And that becomes a debate between do we want shorter time to pregnancy or do we want greater percentage of success overall? If we were to test all 10 embryos that this woman has, yes, it might take 2 years to finally implant the normal one, but at least we'll have implanted it versus if we exclude it from the beginning.
all right, so just to make sure that I understand what you're saying. So generally speaking, when we're talking about performing PGTA, the cases in which we're going to perform PGTA are cases where there's a reason to be concerned or a known chromosomal issue for with the parent, right? Or
No. So PGTA
or
is basically done on anybody, all comers. So in America, at least I know in Israel it's a little
Mhm.
bit different. In America, if I see a couple with regular infertility, no specific reason, I will offer them PGTA on their embryos. And the reason is because we know that if a couple makes 4 embryos, for example, and I find that 2 of them are what's called euploid or normal chromosomal number embryos. If I implant those embryos and her transfer, if I implant a normal chromosomal embryo, she has a very high percentage of successfully achieving pregnancy with that embryo. If I
Right. So
don't test the embryos, I don't know how many of them are chromosomally like what's chromosomally normal and what's not. I could put the one that's normal in by accident, or I could put in one that's not normal and she may not have a successful transfer. And I will not know what the reason for that unsuccessful transfer was. Was it abnormal genetics of the embryo? Was it something that had to do with her lining? So my argument is not just to do it for shortened time for pregnancy, but also in case we fail a transfer, we've now done, I tell everybody, IVF is both diagnostic and therapeutic. We're learning things about you. Yes, I might say a 35-year-old has a 50% chance of normal eggs, 50% chance of not normal eggs. But what if the reason you have not been getting pregnant is because your egg quality is actually worse than other women your age? These are things we can only reveal once we kind of go through these steps.
right. So that it is interesting difference between America and Israel, because in Israel it would be more if there's a known chromosomal issue, or and which is interesting, specifically in the cases that you also mentioned, is cases where there's an argument sometimes to go with a borderline or mosaic finding on an embryo, insofar as cases where we're talking about an older woman or where there's been a history of problems with implantation. It's not a
Right.
standard recommendation here otherwise, and I think that's because there's this also another complicated issue, right? There's, to some extent, it's almost like a stress test on an embryo to perform the PGTA. Not every embryo is going to make it. So I think that's also part of the consideration here. And additionally, it adds a whole other step to the IVF process.
Mhm.
Um, but I understand, it's so, certainly there's a compelling medical case, I think, to be made in both directions. Like what you're saying is that look, you have the opportunity to do something which could potentially substantially increase the odds of successful implantation. Why wouldn't you do it? But
Right.
that's actually those differences between policy, or that question of, is this something that's a standard across the board, or is it something that it's going to be case specific, is going to be particularly relevant a little later when we're going to talk about sex selection. Um, okay, I'd like you, if possible, to give a little bit of an introduction also to PGTM. And that way we'll have a lot of a lot of the medical information that we need, and I'll move in after that to some of the halacha considerations.
Yeah, so PGTM is essentially the same. It's the same technique as PGTA, where we biopsy those cells that are going to become the placenta. What we then do, or how we test those cells and what we're testing them for, is different. So basically, you know, we all can carry autosomal recessive diseases that we're not necessarily affected by. Some of the famous ones in the Ashkenazi Jewish population might be Tay-Sachs, Gaucher's disease, and the Sephardic population might be like congenital adrenal hyperplasia, for example. And even though we may carry them, our children, if our partners are not affected by them because of Mendelian genetics, they're not gonna, our children will not have those diseases. However, if our partner carries the same disease as us, then we have a 25% chance of our fetus not just being, not just carrying the disease, but being affected by the disease. And so, for some diseases, that might be lesser of a big deal, and for some it might be a greater deal. Cystic fibrosis, for example, is a really bad disease that we wouldn't wish on anybody to have, if we could prevent it. So what we can do these days is we can take a expanded genetic carrier panel. It's a blood test, and we can know out of 280 plus diseases, different panels test for different amounts of diseases, what we carry out of the known, obviously the known the known gene diseases. So if I strongly counsel all my patients to do that, especially if we're going through the trouble of everything IVF entails and the expense and whatever. We should at least, I think it's the responsible thing to do in the 21st century, to know if we overlap for these diseases, because even if you choose not to test your embryos for that disease, at least you'll be mentally prepared. That being said, what we can do interventionally is we can create a probe that is specific to the couple's genetic mutation. So they'll give us DNA through a swab or whatever it is. We'll create a probe. It takes about 4 to 6 weeks. And then we can actually test the embryos for that genetic disease. And the probe basically aligns with the genes, and we amplify it through PCR, etc. And we can figure out which embryos carry the disease, which embryos are affected by the disease, and which embryos may be totally unaffected. And then we can not implant those embryos that have that genetic disease.
Okay. Now, when you talk about these genetic diseases, what are the criteria? I know a little bit about what goes on here in Israel. What are the criteria in America for determining what you can perform PGTM on and what you can't?
So you can perform PGTM on any of these diseases that come on these standard expanded genetic carrier panels. You can also do it on some autosomal dominant diseases, for example, the BRCA gene. So if you know that a woman is a carrier for BRCA, there's so many reasons to get tested for BRCA, including a woman's own personal prophylaxis and risk reducing surgeries. But in addition, fertility wise, she can prevent that gene from being passed on to her offspring. And there's a bunch of, ethical questions that might come into play with that as well. But we can test for that too. A lot of times a couple will come to me and say, we have, I have Crohn's disease, for example, was one I've gotten before. Is that something that I can genetically test my embryos for? And so some of these multi-genetic or multifactorial ones, no, we can't. Some of them, I don't know if there's a specific gene mutation. I mean, the literature on this is just, the data, the recent research is a lot. It's kind of beyond me. And I'll send them to a genetic counselor, and usually they'll know if there's a probe or a specific genetic mutation that can be tested for. And so almost anything that we can test for, we can create a probe for. But it is sometimes, for some of these more obscure ones, a discussion.
Okay. So in Israel, there are a lot more limitations on using PGTM. It's not just up to the discretion of the individual patient or the individual physician, but in fact, there are panels. There's a national policy
Hmm.
which lays out. There's some cases, let's say something like Tay-Sachs, which are cut and dry, and there are
Yeah.
other cases. There are other cases which have to be adjudicated on an individual basis by a panel
Interesting.
to see if PGTM can go ahead. So it's a very different. It's
Mm.
interesting. It's just a very different framework for assessing in which cases you would use these technologies, in which cases you couldn't. I'd like to move on, with your permission, to talk a little bit about some of the halachic aspects of these
Yeah.
of PGT.
Yeah.
And here the halachic discussion of this naturally is pretty recent. And it's recent because technologies are relatively recent, which also means that this is one of these exciting cases where it's sort of like halacha information. And at the
Mhm.
same time, because these technologies are already being offered to couples, and it can be critically important to a couple to avail themselves of this of these options, of this type of testing, rabbis have had to weigh in on a lot of these issues. I mean, we started off talking about, sort of like, from a religious framework, that tension between the ability and God's permission to us to heal, and the ability that He's given us to perform this type of testing, and the fact that it's not prohibited, with also some questions about what are sort of the limits of what human beings should stick our heads into, as it were. Um, and so, when it comes to issues of PGT, let's say, for example, the classic case would be something like Tay-Sachs, which unfortunately, it's very cut and dry. If you have two Tay-Sachs carriers who are married, and want to conceive, it's 25% chance of any child being afflicted. Being afflicted is a death sentence, and it's a terrible death sentence at that, at a very early age. And Rabbanim started by kind of weighing in on that kind of more clear-cut case. So, for example, here on the sheet, we have Rav Yaakov Ariel saying, "Im yivaled chalila yeled cholet, tzarich lishkol hitev lefi matzavam hanafshi habriyuti, haim הם מסוגלים לנסות שנית." He says, look, there might be couples who might want to try in the natural function, and doing this in a natural way. And it's a real question if that's something that a couple should do. כי אם הדבר קשה להם מאוד, הם פטורים. אך עם רוב הסיכויים שילד יהיה חולה, אל להם ללדת ילד בדרך טבעית. Look, in some cases, we can say that it's up to the couple. They're exempt from procreating, but they have a choice about whether they want to try doing something naturally or not. But in a case where most of the chances are, let's say with Tay-Sachs, most of the chances are I'm sorry, with Tay-Sex, it's not most of the chances, but in a case where most of the chances are that the child is going to be sick, they should not go ahead with not natural conception. I think when he's saying most of the chances, he doesn't mean that it's a higher chance that they'll have that child, but that given the carrier status, if the child is
Yeah.
afflicted, then the high chances are that it's going to be terrible.
Yeah, that was right.
There's no mitzvah to bring children into the world who are impaired. Whether in terms of the suffering of the parent or in terms of the suffering of the child. I think what's also really interesting that he brought that up is that the considerations here, there are sort of like, there are three parties. There's the parents and how they're going to be affected, and there's the rights of the child, that's his or herself. Rav Asher Weiss says, "Lagabe hashela im chayav lenasot lavi yeladim al yedei afraya chutz-gufit." Well, is it obligatory in certain cases to pursue PGT technology? רק אם יתברר שאין בו פגם גנטי, באמת שאין בזה כלל חיוב מצווה פריה ורבייה, דאין חובת המצווה אלא המעשה הטבעי שיש באדם לעשות. Look, he says, there's not an halachic obligation to perform, the halachic obligation in Puravu does not obligate someone to pursue this type of testing. In other words, you could say, we're not going to have children, we're not going to perform testing. And at the same time, v'dai sheyesh lo odadam, we should certainly encourage couples in situations where they're liable to have children who are deeply afflicted. We should be encouraging couples to pursue PGT. And he says, in that case, we should do everything we can to enable them to have healthy children. And it's clear to me that even if it's not obligatory from the perspective of the halachic obligation to procreate for the couple to pursue advanced reproductive technologies such as PGT, it is certainly something that he would be encouraging, and not just encouraging, but he would see it as a fulfillment of the mitzvah. In other words, a couple could have a choice and say, look, given our genetic profile, we're not obligated to have children. But if the couple go ahead and pursue PGT, they can fulfill the obligation to have children, even though this is not, as it were, the classic natural way to conceive. And there are even Rabbanim, like here in the bottom here, Rav Shlomo Daichovsky, who says that if you have two couples who are carriers for a serious disease, it's prohibited for them to get married unless they're going to agree, or to conceive unless they're going to agree to undergo these technologies. So you have really a range of views, from tolerance to encouragement to saying that it's obligatory in certain cases. And I think as PGT becomes better and better known, and as we gain confidence with the use of the technology in a wider range of cases, we have more and more rabbinic support in a wider range of cases to pursue PGT. So really, from a halachic perspective, in very many cases where it would be medically recommended, a couple is going to be given halachic support in pursuing PGT. What becomes more complicated halachically, and as you were saying, ethically, are cases like the one of BRCA. So, like, let's say in the BRCA case, I don't know, why don't you give us a little bit more of the medical background, and then I'll talk a little bit more about the halachic aspects.
Yeah, I think we wanted to dive into this because we called the session from PGT to BRCA or something.
Well,
But basically,
unfortunately, it's such a high incidence in the Jewish community. I mean, 1 out of every 40
yes,
Ashkenazi Jew is going to be a carrier for BRCA.
yes,
So,
very high percentage. I screen everyone. So basically, based on somebody's family history or who's affected in their family with either breast, ovarian, prostate, pancreatic, melanoma, or even uterine cancer is a little bit more controversial. But if somebody has a strong history, and depending on the age of diagnosis of that family member, et cetera, then they may they may qualify per the American College of Obstetrics and Gynecologists to be tested for the BRCA gene. So I don't know if it's different in Israel what the criteria is, but we have some guidelines that we follow. And if they choose to be, if they do kind of fall into that category, I go through pros and cons with them. The risk of breast cancer is significant by age 70, 45 to 85%. The risk of ovarian cancer, if you have the BRCA1 gene, is actually a little bit greater. That you're at greater risk of developing ovarian cancer versus the BRCA2 gene is about 10 to 30% by age 70. And so, what is the reason for testing? I go through the pros and cons with them. Like I alluded to earlier, you can actually have risk reducing surgery on yourself. So, if you got a prophylactic bilateral mastectomy, you could highly decrease your risk of breast cancer. And then if you had a bilateral oophorectomy, so if you removed both your ovaries and the tubes, you could also very greatly diminish your chance of ovarian cancer. And so, how do you remove your ovaries? A lot of times, something to think about before you do that is that you're done having children, or that if you're young, if you're kind of getting to that age, we usually recommend it by about 35, 40 or after childbearing, that maybe it's time to freeze your eggs and then think about removing your ovaries. So it's a lot of very serious questions. But what it means for us kind of in the context of PGT is that we can test the embryos for the BRCA gene. And like I said, kind of an ethical question. I think this might be, am I moving on to our next slide if I talk about the ethical discussion about BRCA?
Sure.
Yeah. So basically, like I had a patient once, and this will stick with me forever, who said to me, we were discussing the BRCA gene and whether she should test. She was doing egg freezing. So she didn't need to fertilize them yet. This is not a discussion she's going to be having until she makes embryos, because we cannot test eggs. We can only test embryos. But we were discussing, do you want to get tested for the BRC? Sorry, she knew she was a carrier. Would you in the future want to be testing your embryos for BRCA? And she said, on one hand, she does. And on the other hand, she's a BRCA carrier. And what would have happened if her mother had, tested her embryos and not implanted her? Like, her whole existence was not just about her cancer potential for cancer diagnosis. She has a whole life. And the BRCA gene is one aspect of it. And so that was, very moving for me. This person it's a sum of parts that's so much greater than just that gene and what it could mean. And on the other hand, for some people it's devastating. So it's a really difficult conversation. I'd love to hear the halachic perspectives on that.
Yeah, I mean, it's very difficult because it's different. It's different from, let's say, a quote unquote, I don't know if we can say standard, but a standard case of PGTM, because here we have a situation where, on the one hand, yes, we're talking about a dominant gene. So if someone has it, a 50% chance, or I think it goes up to 75% if both parents are afflicted, are carriers. And being a carrier means that it affects you. It affects you for life. That's a huge that's a huge percentage chance on the one hand of children taking this on. And again, it's something that affects you for life, insofar as even before you get to the age where you would be having cancer, there's additional screening, and as you discussed, there's the possibility of a prophylactic treatment, which has a lot of implications on its own. It sounds simple, prophylactic treatment, but let's say an oophorectomy, moving the ovaries, is not a simple thing. And it affects all kinds of life decisions about childbearing. It affects the life of the couple. It affects their intimate relationship. It's a big deal. So on the one hand, you have this mutation where the current medical guidelines for how to handle the mutation, because of the uh, much higher incidence of cancer, are really things that are going to affect someone's life. And on some level, it can be for people almost like a cloud hanging over them. On the other hand, we're talking about something that it's, even though the odds are unfortunately much, much, much higher of becoming sick with cancer when someone has BRCA. Number one, it's not guaranteed. It's not 100%. And number two, this is something that often is a later onset in life. It's something that most typically, though of course there are exceptions, it can happen earlier, but most typically it's not happening before someone's 40s or 50s even. Um, and that's many decades of potentially high quality life where someone's not being affected. It's like the case you were talking about. What for a woman to say something along the lines of, "Well, you're going to select me out genetically." Part of why she's saying that is because, thank God, even though she's a carrier, she's lived a very full life up to that point. Many of us who are carriers are, a carrier can go a very long time without having cancer. So the question with PGTM is sort of like, well, you have it in this moment. We can take these steps to stop this disease and to stop this gene line in the family. Of course, you don't know what's going to happen with marriage, but to stop it at least from our end. And on the other hand, it's not something that's necessarily where the positive effects of it aren't necessarily going to be felt for decades. And what's going on medically doesn't stop in its tracks. What happens, for example, if a few years from now, God willing, this should be our problem. If a few years from now we have a much higher developed techniques for dealing with breast cancer, for detecting and treating breast cancer, would we say that what we did here was for naught? Is it possible that we're going to discover that there's some genetic advantage to BRCA? Someone, a nurse I was speaking with the other day, said it seems that maybe it enhances fertility, BRCA, which is sort of ironic.
No,
Um,
decreases fertility.
so from your knowledge, it decreases fertility. And then what's also interesting, so I'll have to share that with her. What's also interesting is that maybe not. In other words, because we're talking about something that was typically late onset, maybe there was no genetic advantage because the disease didn't often, in times with with shorter life expectancy, the disease didn't come into play necessarily before people were dying very frequently. So you
So
have all these
evolutionarily.
Yes, you have
Interesting.
all these very messy questions. And so how is it how are our rabbanim, when they're asked these halachic questions, how are they supposed to relate to it? So again, as we saw before, Baruch Hashem, the halachic establishment has really been on the whole very supportive of following medical recommendations on PGT in general. But that's a lot clearer when we're talking about a disease that's very likely to come in the near term in a way that's going to affect the child. In the short term, why would there be any hesitation about this type of intervention halachically? Well, first of all, any intervention is something that halacha is going to keep its eyes on. Here we've got questions in terms of the whole process of IVF, things that again we'd overlook in cases where it's clearly necessary for the couple. Let's say there's a fertility issue. We're going to say that, for example, the man procuring a semen sample is not doing something that's wasting sperm. It's not wasting sperm. It's not levatala, but rather it's in order to procreate, so that would be halachically permitted. What about this case where they're actually perfectly fertile? They can have children who are potentially going to be healthy for years. Are we going to say it's permissible? There's some sort of risk involved for the woman in undergoing procedures. Again, it's a risk that we readily absorb in any number of cases. In cases where there's where it's clearly indicated to go through PGTM, or in cases where there's a clear fertility issue, women absorb the risks of the high level of hormonal stimulation that we talk about in these procedures. But what about here, especially given the sensitivity of a BRCA carrier potentially to the effects of estrogen, even if the protocol is going to be different and we're going to be trying to block its effects as we go through it.
No,
So
Lori, that's I was just gonna jump in and say, that's really interesting because there's two scenarios. One could be that somebody is doing all of this to prevent the BRCA from being passed on to their offspring. A lot of times we see people are doing IVF anyways for their infertility and then want to know if they should also add on the
yeah.
BRCA or, for
And in
example,
that case, and absolutely from a medical, and also I think from an ethical, and I think also medical in Israel certainly, and halachic perspective, the bar of what it takes to permit this is lower if we're already in the process, right? Because PGT is basically what a couple's going through, is they're going through all the complications of IVF plus.
right,
It's IVF plus all of these other factors.
right.
Another halachic question would be something along the lines of, well, this is sort of a stress test for the embryo a little bit, going through PGT, PGTA or PGTM. PGTA might be even a little harder, I think, because it's the fifth day, right? Which sometimes it's even harder to get to.
In America, they're both done on the 5th day, and in America, I wouldn't say it's such a stress test. Usually,
Okay,
all
so
our
in America,
girls
you
do
don't see it that
PGT.
way,
I think
which
that's
is
different
interesting.
between Israel and
Right,
America. Yeah.
and also the
Well,
REs
I
have
think
talked about.
what you're saying is that if they make it to the point where they do PGT, then they've made it to, at least in America, they've made it to day 5 of development, which is a really good sign. So we
Yeah.
don't even do PGT on our ones that only make it to day 3. So maybe
Yeah,
in
so
that
in
way, it kind of
Israel,
helps less.
PGTM is often performed on day 3, and not
Oh,
on day 5.
oh,
It depends on the medical center and the particular lab and their techniques, but it's often on
oh,
day
okay,
3.
okay.
Um, in any case, so those are all questions that arise, and this is still not fully worked out halakhically, also in Israel. So on the whole, BRCA, PGTM for BRCA is not going to be suggested. It's going to be raised as an option, and generally speaking, it's going to be permitted by a hospital ethics committee. Here I just have 2 examples of Rabbanim weighing in on this, and they're in different directions. So you have Rav Dov Lior, the last 2 lines of the source on the top. He's a modern Dati Leumi Rav, who says, "Machla she'amura להתגלות בבלד רק לאחר עשרות שנים, נראה שאין לחשוש כלל, אלא יש לבטוח בקדוש ברוך הוא רופא כל בשר, וייתכן מאוד שעד אז ימצאו פתרון רפואי למחלה." His approach is, look, if we've got a sickness that's only going to express itself after decades, we shouldn't be concerned about it now at all. Rather, we should trust in God who heals all flesh. And it's possible that by the time it would be relevant, we're already going to have a therapy. Oh, I should add another halacha consideration, which is that you've got in some of these cases, you've got a perfectly healthy, fertile couple who are going to wind up using contraception for their whole married lives, which is
Mm.
also a big deal. So that's one perspective. But then I also brought Rav Avigdor Nebensal, who's also a contemporary Dati Leumi Rav in Posek, who says, last line here, when we're talking about Zman Hofat Machala, when it's a delayed timing of the disease appearing, Yesh linhog lefi harefua kayom. You're supposed to act in accordance with the medicine of today. In other words, he's basically saying you can't talk about, of course we trust in God, but there are no guarantees. If what the physicians would recommend today, even knowing that this illness will often manifest only decades out, is to pursue this type of technique, then we pursue this type of technique. So basically what he's saying is he's leaving the option open. So what's interesting is that you're going to have some Rabbanim who are going to say, let's hold off on this. This is sort of like a borderline case, more so in Israel than in America, where I think it sounds like it's more standard. But in Israel, it's still somewhat of a borderline case. Let's hold off on this. Don't rush to do this. But you have other Rabbanim who say, no, look, there's room to do this. If the medical establishment thinks that in accordance to what we know now in the medical situation now, there's a compelling case to do this, then this isn't, he wouldn't say it's obligatory for a couple. We heard phrases like obligatory come up in cases of like Tay-Sex. I haven't heard anyone say that PGTM is halachically obligatory for a couple of BRCA carriers or where one is a carrier. But still, it would be an option for the couple to pursue. In practice, at least in my experience of encountering couples who've had a personal experience with breast cancer or with heavy effects of BRCA are more likely to be interested in pursuing PGTM, and couples where it's been sort of more well managed or a case of cancer in the families, it's been survived without as much struggle, are often less likely. So what seems to be interesting is a couple's inclination to sort of stop BRCA in its tracks in their particular genetic line often seems to depend on their personal experience. But on the whole, we see that there are many Rabbanim who are supportive, but not pushing it, and there are others who are reluctant. I think we need to move on to our last topic, which was sex selection. So do you want to just remind us about how it works in terms of PGTA? It's automatic that we're going to know what the gender is, or is there a way not to know if we would want not to know?
It's automatic because it's chromosomal number, and so, potentially there could be a sex chromosomal abnormality that PGTA would tell us about as well. So PGTA will tell us if it's a normal amount of chromosomes, so 46, or if there's an extra copy of one chromosome or what a decreased copy, and then it'll also have right next to it, 46XY, 46XX. 46 potentially could be like something like, Klinefelter's could tell us this is XXY, or Turner syndrome XO. So sex will be told with aneuploidy.
So in your experience, so as you were explaining before, in America, it's standard at least in your practice, to do PGTA for any
Yeah.
couple that's pursuing IVF. So
Yeah.
at this point, we're saying that all the couples are doing this. All the couples are
It's
going to have
offered to
results.
everybody. Yeah.
Okay, so right, so a couple might decline PGTA, but it's going to
They
be
might.
offered to everyone going through
Yeah.
IVF. So on the whole,
Yeah.
it's going to be a standard that a couple going through IVF is going to have PGTA done, and they're going to know, or you're going to know before implantation, the genders of all these preembryos. So the question is this something that you raise and you explicitly discuss with every couple that's looking at this, or is this sort of if they raise it, you'll talk it over with them? How does it kind of work out in practice in those cases?
In my practice, I mean, so some centers are not as big proponents of PGTA, so I don't want to make a blanket statement, but I'd say a lot of private practice in America, and probably the majority, will offer PGTA. It's mentioned in the, in the initial consults, kind of like, this is what we can do at this stage of the, as we're explaining, how IVF works, and that we develop from the fertilization, we develop embryos, and at the day 5, day 6, day 7, they're called blastocysts, etc. That's the point at which I would discuss. We can do a biopsy on the embryos at this point called PGTA. That'll tell us if they're normal chromosomal number. It'll also tell us gender. And I usually do recommend PGTA for most of my
And so
couples.
do couples jump on the gender question? Meaning, is it a standard part of choosing when there's a choice of more than one
I'd say they're all
potentially
pretty
of the
excited
embryo?
about it. And
I'm
yeah,
sorry?
I'd say they're all pretty excited about it. I would say a lot of them choose which embryo to transfer. If all else is equal, they will choose gender to transfer a female or a male. And then some of them will say, rarely will they say, so much of this process has been so controlled for me. I want this element to be surprised. So pick the best embryo. Don't tell me the gender.
That's fascinating.
Yeah.
And what about if do couples come to you sometimes who are not otherwise in the IVF process, asking to pursue it for the purpose of gender
Yeah, so
selection?
we call that IVF for family balancing or gender balancing or whatever. And yes, there are a good amount of couples that come just to do IVF to pick the gender of their baby. And from my understanding, halachically, if they have all girls or all boys, um, there may be like some heter, I guess, for pru or vu. I don't know. I defer to you.
Okay, so the halachic discussion is really interesting. Again, we make this distinction between a couple that's already in the IVF PGTA pathway, or even just in the IVF pathway, and a couple that's not already pursuing it. First thing, and I think this is very important that's on the table. I'm not aware of any halachic authority who says that a couple that has only boys or only girls is obligated to pursue any kind of IVF, even if they go
Right,
through IVF, is obligated to specifically
right.
pursue
Do
this path
right,
for sex selection. I think it's
right.
important to put that out there. This is not something that someone has to do. Question is something that someone can do in terms of Israeli law, and importantly, the Israeli law halachas are part of the picture. In terms of Israeli law, there's some limits on this. It's not automatic at all. It's generally speaking, again, they're different sort of ethical councils that people would have to go through. Certainly, if they're not going through IVF or PGTA to start with. It's much simpler if there's already PGTA, and then on some level they're choosing embryos to begin with. But if that's not what's going on, and again, PGTA isn't standard here for all IVF cases, and IVF certainly isn't standard for every conception. So in that case, it really depends. If a standard criterion would be either that there's some compelling medical reason to do it. Let's say there's a sex-linked disease, right? So that would be a medical reason to do sex selection, or that there is a family layout of 4 children of one gender already, slash and or a strong psychological component. There might be for whatever reason, a couple that, let's say in the, from what I understand in the Arab community in Israel, having a son is of such social importance that if a woman has not yet given birth to a son, her entire world is different than if she's had a son. And that kind of thing is something that's going to be taken into consideration. One of the interesting backgrounds to this is that the Gemara, obviously the Gemara doesn't discuss PGTA for sex selection, but the Gemara talks about
Okay.
couples who are interested in having a boy, or couples who and how that might play itself out. The assumption there is that sex selection is going to err on the side of boys. So, for example, I brought two sources here. Someone who wants to have only boys should make sure that he repeats acts of intercourse when trying to conceive. Okay, and then there's another Gemara in Masechet Nida. What should a person do to ensure that he's going to have male children? And again, the discussion has to do with during relations in particular. And also it has to do with asking with tefillah. There's, a range of different things. The fact that the Gemaras here are taking it for granted that there might be a preference, but also without criticism, raising practical suggestions that someone might undertake. Now, this isn't a hardcore halachic discussion here. No one in the Gemara is saying this is what a couple have to do. But the idea that the Gemara is sort of like in this very neutral way is, or maybe even more than neutral, saying here are things you could do to try to enhance your odds of having a son, opens the door to saying that we're not talking about a halachic crisis, as it were, for a couple to kind of pursue choice in this matter. I see their time is low, but just very, very quickly. So you really have, again, you have different schools of thought in terms of relating to this. So I brought, let's say, Avram Steinberg, Rabbi Dr. Avram Steinberg, who's a major expert in halachic medical ethics here worldwide, and particularly in Israel. He expresses some reluctance. He talks about those cases that I mentioned, which are cases where in Israel it's going to be more widely accepted or permitted to explore PGTA for sex selection. And at the same time, expresses some reluctance that this would be done on a regular basis. Is there a slippery slope? Are we concerned about where this is going to lead us? Like you were saying, blue-eyed children. Are we concerned about how freely we want to be? Back to this question of intervention, right? Intervention when it's rapo yirapeh, when it's for the point of healing, is that different from intervention when it's just about preference? And how do we really look at that? So that's you've got that on the one hand, and then you have Rav Yuval Sherlow, who's a national religious rabbi and ethicist. And what he says is that look, we have these Gemaras that talk about this in a very open way. And back to that question of, well, if something isn't explicitly prohibited, who are we to prohibit it? Why shouldn't it be permissible for a couple to pursue this if they're interested in it? So you really have different voices in the rabbinic establishment about this question of sex selection as well. There's no matter where you are, there's going to be some sense that this should be talked over and worked through, especially since, as we discussed, PGTA, PGTM are going to involve different processes for the couple from regular conception. And again, the bar is certainly going to be higher for a couple that's not already in the IVF process or already pursuing PGTA, but for other reasons. But the door is not closed on this. At the same time, it's not where it is, I guess, in America, where it's sort of very much wide open. It's the door is open, but there's sort of like a process, as it were, for stepping through it. And I think that's sort of maybe a nice way to sort of summarize what I've gotten out of our session, which is that we have these amazing technological breakthroughs in the realm of fertility. I mean, the things that you can do, Dr. Wertheimer, were
amazing.
unimaginable until very recently.
Yes.
And those capabilities, it's growing all the time. I'm sorry, what did you say?
Yeah, I agree with you. It's mind blowing what we can do with our technology these days, and it's important to remember that even I try and remind patients too. Science and God are not mutually exclusive. So.
Yeah. And so what we're seeing on the halachic end is very much a recognition that science and God aren't mutually exclusive, the sense that Hashem is the one who's given us these tools. And at the same time, the halachic establishment, while, as I said, leaving this door open and certainly sometimes really pushing people through this door
Right.
where it's very strongly medically indicated in
Mhm.
cases where the medicine and the ethics are less clear. I think there's a little bit more of a cautious approach. Again, not
Right.
slamming the door, but more of a cautious approach because this isn't sort of the natural course of things. Both saying that couples aren't obligated to pursue this type of option, let's say for Purvu, to have a boy and a girl, but also beyond that, saying, well, let's not jump into this world of medical technology and intervention unless we're sure that this is what we want to, that what we need to pursue, either medically, what we're advised to pursue medically, or something that we really have a compelling other need to pursue, in terms of thinking about the ethics. And the field's really developing. I mean, if we were to have the same conversation, if we had it 5 years ago, and if we'll
Yeah,
have it five years from now, I imagine that the conversation will not be the same.
I agree. I agree. There's a lot of stuff coming down the pipelines that I think will be very interesting for our health and halacha of 2027.
Yeah. So anyway, thank you so much. It's been such a pleasure to learn from you
Yes,
today and with you
yes.
today
Thank
about this.
you. Thank you.
Okay.
Mhm.